Good afternoon and welcome to the Health and Wellbeing Board. I would like to introduce my name's Katrina Cope. I'm the Senior Democratic Services Officer and I provide support to the Health and Wellbeing Board. I would like to just bring members' attention to the first item on the agenda, which is election of chairman. Can I invite nominations for the position of chairman? Do we have any nominations, please?
I'd like to nominate Councillor Woolley. She's been our chairman for a number of years. I think she does an excellent job. She's really works well with our partners, and actually she has extended her work to nationally, and I think she brings a lot back to Lincolnshire to us so that we can learn from others. So yes, I'd nominate Councillor Woolley.
Do we have a seconder, please?
Yes, I'm happy to second that.
We have a proposer and a seconder then for Councillor Mrs Woolley to be the chairman of the Lincolnshire Health and Wellbeing Board for 21-22. Can we have a show of hands, please? Anyone against? That's carried then. So we'll just wait for Councillor Mrs Woolley to take a seat before we move on to the second item on the agenda, which is the election of vice chairman.
Okay, thank you everyone, and thank you very much indeed, Councillor Bradwell, for your very kind words. It's much appreciated. And thank you, Councillor Kendrick, for your seconding. Can I move on to item number 2, election of vice chairman? I would like to nominate John Turner as the vice chairman for the forthcoming year. Can I have a seconder, please? Thank you. That's Elaine Bayliss. Thank you, Elaine. Can I have... oh, that's it. Yes, because I nominated, didn't I? So, John, would you like to join me? And you've got to sit on that side, apparently. Right, so that everybody's aware, you can see the microphones in front of you. If you point the mouthpiece so that it will move, it's on a wire so that you can lower it or whatever you like to do. If you want to speak, indicate to me, and then you will have to press that button that is immediately below the Lincolnshire logo. As you'll see on mine, there's a red light that comes on, and that's when you're able to speak. Can I just remind you to turn your microphone off again when you finish speaking? So it's a little bit better than Teams, because at least we can hear you and shout, or not shout, you're on mute. Okay, and then I think the other thing that I wanted to do, I'm delighted to see you all. I genuinely am delighted to see you all here. This is actually, I think we're probably about the first in the country to have the Prospective Partnership Board in this setting. It's been slightly lonely, wondering whether the NHS and indeed the Local Government Association were sort of going to put their size 12s in. To date, they haven't done, so touch wood that they don't at all. Those of you that have read that really riveting tome around the design of the ICSs will know that our dear health colleagues, and I say this tongue-in-cheek, are saying, oh, any way you like, and, you know, we're fairly flexible and we're relaxed about how you set things up. Well, I hope they continue in that vein. So it's just a case of, can we all go round very quickly? We will go front to back in each section. Just introduce yourselves and say which organisation you're from. So I will kick off with you, Alison.
Hello everyone, my name's Alison Christie. I'm a Programme Manager in Public Health and I'm technically the Business Manager for the Health and Wellbeing Board.
Dr. Sunil Hindesh, I'm the Chair of the PCN Alliance and a Clinical Director of the PCN.
Good afternoon, my name's Sean Lyons and I'm the Chair of Lincolnshire CCG.
Rob Kendrick, I'm County Councillor representing Metheringham Rural Division.
Richard Wright, I'm leader in North Kesteven District Council and I'm the newly appointed District Representative.
Callum Cook, County Councillor for Stamford East and also leader of South Kesteven District Council.
I'm Derek Ward, I'm the Director of Public Health for the county LCC.
Afternoon all, Andrew Morgan, I'm Chief Exec of United Lincolnshire Hospitals NHS Trust.
Hello, I'm Maz Fosh, I'm Chief Exec at Lincolnshire Community Health Services.
Good afternoon, I'm Elaine Bayliss, I'm the Chair at Lincolnshire Community Health Services NHS Trust. I'm also the Chair at United Lincolnshire Hospitals Trust.
Good afternoon, I'm Emma Tatlow, Chief Executive of Active Lincolnshire and here today representing the community and voluntary sector.
Michael, I'm Councillor Patricia Bradwell. I'm the Deputy Leader of the Council and also have responsibility for Children's Services and now Save for Lincolnshire Partnership as well. And it is lovely to be back in public.
Afternoon, I'm Sarah Connery. I'm Acting Chief Executive at Lincolnshire Partnership NHS Foundation Trust.
Afternoon, I'm Kevin Lockyer. I'm Chair at Lincolnshire Partnership NHS Foundation Trust.
Good afternoon, William Gray. I'm County Councillor for Horncastle and the Keels.
Good afternoon, I'm Katrina Cope. I'm a Senior Democratic Service Officer and I'm responsible for the Health and Wellbeing Board.
I'm Wendy Bokett. I'm a member for Wainfleet and I'm Exec Board Adult Care and Public Health.
Councillor Sue Rawlins, again County Council representative. Thank you.
Afternoon, just to confirm, I'm John Turner, the Chief Executive of Lincolnshire CCG, also your Vice Chair, and yes, it's great to be able to see everybody again.
And hopefully everybody took notice of when we were doing the first item. I'm County Councillor Sue Woolley and indeed District Councillor at South Kesteven, and I'm now Chairman of the Health and Wellbeing Board and portfolio holder for various things that means a lot of ink within the County Council. Thank you very much indeed. Can we now move on to item number 3, apologies for absence and replacement members. Thanks, Katrina.
Thank you, Chairman. We've received apologies from Heather Sandy, Executive Director of Children's Services, Sarah Fletcher from Health Watch, Oliver Newbold from NHS England, and Jason Harwin, Chief Constable Representative, Lincolnshire Police. Thank you.
Thank you. Declarations of members' interests. Are there any members that have any interests at all they wish to declare? No? Okay, thank you. We'll now move on to the action updates on...
Excuse me, Chairman, don't forget the minutes at number 5.
Oh, do I have to? Right. Minutes of the previous. Now, my style is I really assume that you've read these. I don't intend to go over anything that's within those minutes, but only go in for accuracy. So if you would like to raise your hands or indicate at the very least if there's anything, certainly for those that were here, if there's anything that you are not happy with.
Excuse me, Chairman. We've had notification from Sarah Connery that she's missed off the list of attendees.
She's got her hand up behind you.
Yeah, I didn't want to forget though, that's all, Chairman.
Okay, thanks very much indeed. Sorry about that, Sarah. We'll make sure that that's corrected. Anything else from anyone? No? Okay. In that case, again, I will move to the action updates this time. And again, this is just that matters arising. So for speed and accuracy, hopefully you will note anything that did arise from the last meeting is within this section. And I don't think there is anything else to update other than, Alison, that you'll see at the, I think it's at the very end, that there was a reference to writing a strongly worded letter to Nadine Dorris, who is the minister or the applicable minister. We wanted to put a response into the mental health white paper, and unfortunately, you know, all the good work that we're doing in Lincolnshire, there was no mechanism for being able to send in a system-wide response. So Shirty letter was sent off, and we got not only did we get a response back, but we also got a template in order to be able to make that system-wide response. So thanks very much indeed for those that organised that. So we now move on to the first decision item, and that is the terms of reference. Alison, I believe that's you.
It is me, yes. As you hopefully you're aware, of the last sort of 5 or 6 months, we've been reviewing the terms of reference of the Health and Wellbeing Board to incorporate the functions of the ICS Partnership Board. Those proposals were discussed at our last meeting on the 9th of March with a recommendation to present them to full council on the 21st of May. That happened, and the council agreed to our recommendation to make the changes to our terms of reference. So we're required at every AGM meeting of the Health and Wellbeing Board just to reaffirm our terms of reference. So they're attached in Appendix A. So really I'm just asking the Health and Wellbeing Board to say that they agree to the new terms of reference now that we have the new membership as well, that was signed off by the council on the 21st of May. Thank you.
Okay. Are there any comments arising from the terms of reference at all, or anything that anybody's unclear of? Councillor Wright. Richard.
Thank you, Chairman. As I said earlier, I'm the newly appointed rep, but I come with copious notes provided kindly for me. And I'm aware that at least one of the things I'm going to mention now, I know has been previously discussed, but it needs to be aired again, I think. And one of those is the membership of the board going forward, especially with regards to the way that ICS is developing, and the impact this has on the wider detriments of health, and also on what the national model, although we talked about, you said it can be this, it can be that, there actually is quite a strong steer on this, and there's a feeling amongst the district councils that there should be wider representation, that it's not about who controls what, it's not about who's, you know, what budgets or whatever. We're all representing the same people, but we all bring different attributes to the table, and the diversity amongst the district councils, both amongst the population types, the areas they cover, means that we think that there should be actually more than one representative going forward, and that does fit with the wider national model than is currently demonstrated. And also on the key roles and responsibilities, then we think that the wording needs updating to reflect a more genuine appointment for the district council representative, and would ask that there's a further bullet point added which says provides reports in accordance with the national model of the ICS, which is missing from the current document. We feel that will reflect more partnership working rather than just sending in some kind of representative comments, which seems to reflect at the moment.
Has mine gone on? Right. You end up with a crick neck because you're all the while checking that the little red light's on. Thank you for the comments. I think it's a fair point, it's well made. If you said to me in 12 months' time, or 12 months hence, one thing I can look you in the eye today and say is the membership of this board more than likely will not be the same in 12 months' time. This is a starter for 10. I hear what you're saying. I'm delighted that both you as the leader of North Kesteven and indeed Kellam as the leader of South Kesteven are here in your roles both as county councillors and indeed leaders of your districts, and I really hope that you will take and share the information back with your pertinent districts. Likewise, certainly Councillor Bowkett and myself as twin hatters, it means that there are other avenues for district councillors to input and indeed cascade out to. You're absolutely right. If we're going to make this work, then we've got to have as much buy-in as possible, and all I would ask is that you give us a little bit of time as to working out exactly who the pertinent people are. And I'll say here and now that I'm pretty convinced we're missing the university sector. We've got the med school, and suddenly it's a case of, oh, where are we with that? I think it's a work in progress, and I think it's something we might even look at a small working group to just test out whether the representation is right for the ICS partnership going forward. So I hope you'll accept that.
Thank you for... I was going to say, can I come back at some stage on that?
Thank you. Yeah, it's a very valid point that Councillor Wright's made, but I'd just add that we have actually got 5 district councillors who sit around this Health and Wellbeing Board, and we also have Health, Housing, Care Delivery Group that sits under this board, of which we have all of the district councillors sitting around there, both members and officers, all of the health partners and everybody else. So everything that happens here does get brought down to the Health, Housing, Care Delivery Group. So I do think that districts are really well representative, but I do understand where this argument has come from, and it will continue to come from. So thank you.
Councillor Wright, Richard.
Thank you. I'd like to say it's a discussion, not an argument. But no, we'd welcome the, as you said, the working group, because as I don't want to labour the point, and the fact is that I'm sitting here as a district councillor, not a county councillor, you know, and have to be very clear about the distinction between the roles. And it's just with the ICS, obviously with the going live date, then there's a concern that we're not invited to the stable after the horse has bolted. And so therefore that is felt that there's probably an opportunity for wider input into that at the start of the process, rather than after there's some framework put in place that we're perhaps asked to, you know, contribute to afterwards. So that's why there's the feeling now, and I know it's been visited before. As I said, I know that it's been discussed before, but it's just felt that it needs to be put back on the table. And so if you are suggesting a working group to look into that, it would be appreciated.
I think that we can certainly look into that. Thank you, Alison. Have you scribbled your note down so that you're ready for the next item? Sorry, is there anyone else that wanted to speak on that particular item? No? Okay. It's a decision item, apparently. Right. Can I now go to the actions that are required? The Health and Wellbeing Board is asked to agree the terms of reference, procedural rules and board members' roles and responsibilities as set out in Appendix A. Are you all in agreement with those actions, or that action rather? Thank you. Thank you. Okay. We will now move on to the next item, which is the Joint Strategic Needs Assessment. Alison.
Yes, that's me again. One of the responsibilities of the Health and Wellbeing Board is to produce and publish a Joint Strategic Needs Assessment on the current and future health and wellbeing needs of the local population. Up until COVID, we were doing an annual review programme of our JSNA, which is published on the Lincolnshire Research Observatory. It's an online resource and is publicly accessible. With COVID, unfortunately, we've had to stop that review programme and put it on hold. But there are a number of issues that now make it pertinent to restart a review programme. One of the issues is that the LRO is due to be turned off in March 2023. So we need to look at moving the JSNA onto a different platform. So as part of that process, we want to look at how we can reformat the GSNA, redesign it to use some of the learning from COVID on how we present and make information and data accessible to wider partners. So we want to make the use of sort of dynamic dashboards and being able to present data in tables and graphs, which we're currently not able to do on the LRO. Also, the process we have in place at the moment is quite a laborious, inefficient way of reviewing the GSNA. We have 34 topics currently, and it does take up to 3 to 6 months to review each topic, and that does involve a lot of work and a lot of input from numerous partner agencies and people within public health. So we wanted to look at how we can streamline that process to make it a little bit more efficient by using the new technologies and way of presenting data. So we want to take this opportunity to redesign the GSNA, so to move away from the topic-based approach which we've had since 2007 and move towards a life course approach so that we're able to actually show the interdependencies between the different themes that are in the GSNA and be able to tell that story about what the health and wellbeing needs are in Lincolnshire rather than being a series of isolated topics that don't really sort of knit together very well. So we're proposing a life course model based on 3 chapter areas, which are start well, live well, and age well. And under there, there'll be various themes and issues that are then discussed within that approach. And Appendix A sort of sets out the types of information that we want to put in there. It's not an exhaustive list. It's based on what we've currently got in the GSNA. So there will be opportunities to perhaps look at other areas that aren't covered by the GSNA at the moment. So to include some information around wider topics as well. One area that is missing off that list is neurological conditions. So that was an omission on my part, I'm afraid. So that should appear under the long-term condition heading that's under living well. So really, I think this provides an opportunity to also re-engage our partners in the process. It is a statutory responsibility on the County Council and the CCG currently, although there will be still a responsibility through the ICS to engage with the GSNA. So I think we need to look at how we re-engage partners in the process, because I say we've had probably 18 months where we've done no work on the GSNA. So what I'd like to sort of hope moving forward is that we identify those groups that already exist around these areas of work and use them as some of the mechanisms through which we do this work, so it's not seen as just a public health responsibility to do this. Public health facilitate the process, but we need everyone's buy-in and contribution to actually have a GSNA. So that's all.
Thank you, Alison. Before I ask or open it up for comments at all, I think it's fair to say, Alison, that we're sort of thinking, oh, there's not been enough work done recently, but in the wider scheme of things, actually, we're one of those councils and CCGs and areas that actually have quite an up-to-date GSNA in comparison to a lot of other areas.
Yes, we benchmarked. I think we looked at roughly 50 other authorities or health and wellbeing areas, and we were one of the most up-to-date GSNAs, even though we'd done little work on it since 2019. There were some that we looked at that hadn't updated since 2013. So we have got a very current GSNA compared to a lot of areas. But I'd say a lot of other areas have used technology to present their information a lot better than we have. So I think we just need to look at how we use technology to now improve not only the way we present the data, but how we do the process as well.
Derek.
Thank you. Just to reiterate Alison's point, our GSNA, whilst it's been delayed to some extent, is still one of the most up-to-date. But that doesn't mean the data hasn't been updated on other websites. So we use a lot of Public Health England data, which continually gets updated. So we have the most, and we use the most up-to-date data available to us at any given time to inform our decisions. But the key point I think Alison's already made is that we need to change the technology so that a lot of that process is automated. We've done that, and we've spent a lot of time with COVID reporting, as everybody's aware, to make sure that that's up to date on the day that national data is updated, our dashboards update, and that's what I'd hope we do with our JSNA. I think the other thing that I'd flag up as in my role is that whilst the Public Health Division leads this and we have the capacity and are quite happy to continue to do so, there is a wider programme of work that we are leading around population health management, and that umbrella work is about making sure that all of our partners are feeding through and having a say on what data and how we turn that data into intelligence to inform what we do in the future. That's going to be fundamental for the Council, it's going to be fundamental for the NHS, and it's a core plank of the development of the ICS, which I'm sure John will touch on later.
Thank you, Derek. John.
Thanks, Sue. Actually, I was going to say much of what Derek's just said. Our JSNA that we've got in the county, I think, is strong and effective. It clearly needs to evolve, but we're building on, I think, pretty strong platform. So, from our perspective, very happy to work with Derek and the team in terms of just how we, work our way through the technology issues and get it to the position that Derek has described. I think going forward for this board and for our ICS, the question more is about how we make sure we use the JSNA information in a more dynamic way than we have so far. And I see it as a foundation stone, really, of all the work we want to do together. So whether that's, as authorities or look at SUN or the primary care networks, our colleagues in the trusts, so there's, we almost need to have it to be almost the go-to point for a start of any conversation about health, well-being, and the evolution of services in the county, and how we best tackle the health improvement, health inequalities piece, and all of that. So very, very supportive of this approach. I've just got a couple of questions I think would be just helpful for us to understand. Firstly, in changing from the current approach to the new approach, do we lose anything along the way? And secondly, do we create any points of duplication along the way as well? So just looking at the start well, live well and age well, for example, mental health actually fits across all three. So it'd be helpful just, I think, just to understand that we're not creating any issues we'll need to just pay attention to going forward. Thank you, Sue.
Okay, in terms of not losing anything, the current JSNA will still be live until we're ready to republish the new design JSNA. So we're looking, the timeline that's in section 1.4, I think, suggests that we will republish the new JSNA by March 2023. So we won't turn off the current one until that's up and running. In terms of not duplicating, yes, that's something that we are looking at to make sure that we don't. Obviously, at the moment, we have two topics on mental health, one that covers children, young people, and one that covers adults. So the thinking is at the moment we'll probably do a similar thing in the themes. So it will be mental health with a focus around children and young people in the Start Well topic, and then in the Living Well topic, it will be around adults. So that's sort of the thinking we've got at the moment, but it's still very much work in progress, that planning stage. Okay.
Does that answer your question, John?
Yeah, it does, but I would appreciate a comment from Sarah Connery on this as well, Sue, please, if that's possible.
I've got a number of speakers, but perhaps as it's pertinent to you, Sarah, I'll let you come in first. Thank you.
Thank you, Chair. Just to pick up on John's point, really, it's the absence of autism was a concern for me, which is obviously all age as well, but I'm more than happy to work with Alison on how that might be reflected. Thank you.
Thank you for that point. Tricia.
Yes, thank you. Well, I'm pleased you've just forgotten about neurological conditions, because I do remember when we did the first JSNA, that was a sticking point. And I did have a resident who lives just up the road from me ringing me up on Saturday, saying she'd noticed that it was missed off, so would I raise it today? So I'm really pleased that you're adding that in, because it does cover a multitude of diseases, and very important ones as well, because some are you know, just change your life completely, don't they, like Parkinson's. So really pleased that's in. I just wanted to also pick up on what John was saying, because I'm thinking of Derek's last Director of Public Health's report, where was it the burden of ill health, or was it called something, a burden of global burden of disease, which we thought would be a depressing document, but actually it wasn't. It was really very interesting. And I think moving from that, I think for us all, and especially in district council areas where you can drill down, because the maps that Derek did in that document was really interesting. So you go to the coast and probably we've got obesity, people smoke too much and that, but you could go down into South Holland and you would have other conditions. So I think for the Health and Wellbeing Board, that would be really interesting for us all to understand. I mean, I understand it because I've been here a long while and worked very closely with Derek over a number of years, and it you know, it does become interesting. And I think for district councils, you might already know this, but you know, there will be particular hotspots because of probably occupations and things like that. And I think that's something that we ought to know about. But actually, for our health professionals who are providing services, they really, you know, if we've got a problem in an area, then obviously any agency that's working there really ought to know about that and how we can help people to actually, you know, I'll use the smoking one, stop smoking, which is very difficult if you smoke, I know, or drinking or whatever. So I just think that might be interesting in that document, because I know what we've had, but whether it could be an appendix, but I just feel that sort of information really makes you understand very quickly instead of reading pages of words sometimes.
Yes, I'll come back. I absolutely agree with you. I think that's one of the drivers for us wanting to redesign it and embrace some of the new learning and technology that there is around there, because we will be able to do maps that show hotspots and pull all that information together visually, as well as providing some narrative around it. And I think that's the beauty of trying to move to a more dynamic approach that, yes, we're hoping to be able to do that. I can't guarantee it will be from the 23rd of March, March 2023, but certainly that's an aspiration. I think that all depends on the sort of the technology side, which isn't my area of expertise, I'm afraid, but yeah, that is our aspiration. Yeah.
Sunil.
Thank you, Sharon. Alison, Derek, thank you for this. I really welcome the proposed way forward in terms of it feels that it's more holistic rather than disease specific, because the needs of our people are not just a single disease. Even if you look at the disease model, we have people with multiple morbidity. That's a reality of today. So we really got to start and look at the whole person and really welcome the move to population health. This will be PCN territory. If you look at all the documentation, PCNs are going to look at this and really want to know, as Councillor Bradwell has just said, what's your local population, what's the need, and how do we best address it? I'm just a bit, the timescale of publishing by 2 years hence nearly, I wonder whether we could do some interim work in the meantime, because the needs are there and very real right now, and I suspect will become even more apparent as we come through lockdown and through the pandemic. So really welcome the proposal of the 3 age brackets, if you like. I think it'll capture an awful lot of the multiple morbidity, which we really want to address, but also looking at needs in the round rather than just single disease. So look forward to the work.
Yeah, it was just to give the board some assurance that we will continue with our JSNA. It is up to date. There's a huge range of other data sources that we use day in, day out and share with all of our partner organisations. So if and when we are reviewing any particular topic or geography, we will use that data, the JSNA, as a statutory entity that we have to produce. The technology bit, and I'm sure Councillor Woolley will cut me off if I get too nerdy, the benefit of changing the platform and the technology is, if national data is updated today, then once we have the technology in the right way, the primary care network profile for a particular place will be updated tomorrow because it will be automatic. Whereas at the moment, what we need to do is we have to pull all of those data out and we have to update manually the reports. And understandably, that's quite a laborious process, which Alison alluded to when we go topic by topic. So the idea is to pull all the data through, to have a technology that we can then present the data in the round at the right geography, whether it's district council area, whether it's a middle super output area, whether it's a primary care network area or a GP practice catchment area, so that the people who need it have it. It's the most up-to-date data that we have, and there's issues there, but it's the most up-to-date data that we have, and so we make better decisions based on that. That's what will take time. In the interim, the assurance for the board is we will continue to do what we do, and we'll continue to push on and try to make sure that we increase the pace with which we do it.
I'm going to try and outmaneuver you now, Professor Ward, as far as technology is concerned, so wait for the big fall. I think it's really important that we take notice of this as a system, because within that design framework are overtures around the digital side of things and making sure that we've got something that is capable for all of us to look at and all of us to read, and we need something that is fit for purpose. So, you know, I beg of you all that we keep an eye on it and make sure that when the conversations come round that we're making sure we've got something that's fit for Lincolnshire residents. Councillor Wright.
Thank you, Sue. It's obviously this life course approach is sensible, and John mentioned data, and Trish and Derek have both mentioned something with regards to hotspotting and data, and it's important. We think that the review of the JSNA aligns with other key pieces of work, so it enables those wider data sets to be easily available, or more available than they currently are. But with regards to, I think John said this, what's missing, just questions about what's possibly missing, or we can't see at the moment, is there's several subgroups at the moment supporting the current JSNA. Are they going to continue? And with regards to key factors, especially with the wider detriments of health, then there's financial inclusion that actually goes across all three of the life course, and how is it proposed to handle those? And there's no reference to air quality or wider environmental effects that impact on people. So surely environmental factors should be a key factor that's included there. Thank you.
Thank you. I think you make some very fair comments there. Alison, do you want to respond?
With regards to subgroups, yes, we will be looking at existing groups around all the various areas, the theme areas, to play a part in this. So rather than setting up new groups, we'd be looking to, say, use the housing, health and care delivery group to pick up the housing elements, look at various environmental groups. We've got to pick up things like the environment and the air quality you've mentioned. We currently don't have a topic on that, but that doesn't mean to say that we can't include it going forward. So I think things like that are things that we can pick up as we look at the planning and the design of the new one. Yeah.
Okay. Do I have any other speakers, please? Councillor Kendrick.
Thank you, Chairman. I think holistic is one of the key words in this, and so many conditions and situations are interrelated, whether it's mental or physical health. So I think that's a very important aspect to bear in mind. I'm also pleased to see young carers included in the list here, because I think that's something that's so often overlooked. And I recall in my past having some detailed contact with young carers, and it struck me that they're often overlooked. But it's a great impact on their lives if they're a carer. So I think that's a very interesting and significant issue there. Thanks.
Thank you for that. Any other speakers? Okay, can we now move to the actions required? I'm not going to laboriously read them all out. Can you indicate your agreement, or if you have a really violent disagreement with any of them, let me know. Are you all in agreement? Yep. Thank you. Thanks very much. Can we now move on to, this is the riveting one, isn't it? Hope you're all sitting up and you've got your ears pinned back. Okay, it's the Pharmaceutical Needs Assessment. Alison.
Yes, it's me again, I'm afraid. The Pharmaceutical Needs Assessment, yes. This is another requirement of the Health and Wellbeing Board to produce and publish a P&A every 3 years. We were due to publish it last year, but the government suspended the requirement due to COVID. So we're now required to republish our P&A by 31st of March 2022. Our current P&A, for anyone who's interested, is on the Lincolnshire Research Observatory. So really this report just sets out the process and the timescales for doing that work. We've set up a P&A steering group, which has representation from the CCG, from Health Watch, from the local medical committee and the Pharmaceutical committee, and obviously the County Public Health. We have a specialist pharmacist from the University of Lincoln that's helping us to produce the assessment, and he's chairing the steering group. So Appendix A sets out the terms of reference for that steering group, and Appendix B sets out the outline project plan for producing the P&A. We have quite a tight timescale for getting it done, because part of the process we have to do a 60-day statutory consultation exercise, and we're hoping to run that between October and December of this year. So we're looking to bring the draft P&A document back to the Health and Wellbeing Board in September for you to sign it off, ready for that consultation exercise. We're currently doing some pre-engagement with community pharmacies and dispensing GPs, just getting some initial views around their thoughts around pharmaceutical services in the county. And we're also, through Health Watch, are doing some engagement with patients and service users as well. So they're undertaking that as part of their engagement they're going to be running during July. So that information will help inform our assessment, as well as the usual sort of data analysis that our public health intelligence team will be doing. So I say it's one of those things that we have to do every 3 years. And I say, unless anyone's got any questions, the process is set out in the paper.
Always remember, it is our pharmaceutical needs assessment. It's not the county council's.
Now I sound like a bent record or whatever you would say, but actually I think this is quite important, because I live in an area where a chemist is not, they're not open that often. They're definitely, for us to go, if we want a chemist on a Sunday, we're either going 20 miles to Boston. There's not one open in Louth. I needed tablets very urgently. I ended up coming to Lincoln. There was only one chemist in Lincoln. The rest had to go up to Grimsby. So, you know, if you desperately need a change of drugs and your GP won't give you them, which they could have done, but because I live in the village, they don't dispense to me. We were running around the county. Now, I'm not just saying this for me. I think in rural areas, you know, chemists could dispense for a couple of hours on a Sunday in say, a 10-mile radius. Because I think more and more, you know, people are, you know, you do need something, and you can't get things from a hospital because their pharmacy is often very, you know, closed at weekends as well. So for me, we do need to map how people in the more rural areas. You're right if you're in Lincoln, probably Sleaford, but it is the more rural areas, and especially if you can't drive, you're an older person, there's no buses, you know, so we do live in a desperate area, a bit of a desperate area. But a lot of people live in those areas, and I just think, you know, we should be looking at where can somebody get some help for drugs. You shouldn't, we talk about, and Sunil will say this, you shouldn't always be going to your GP, should you? And GPs don't work on a Sunday, so that means then you're going to, you know, an out of hours. We would have to get ourselves up to Louth, to the out of hours place up there. So I think this is important, being a rural county, that people can, you know, and if you've got a baby with a high temperature and you can't get some Calpol or something, that's really serious if the baby's got a raging temperature. So I think, you know, we just give this the nod, but I think there's more to this about services that our residents need, not always, but when they're poorly. Sorry to go on.
Thank you, Councillor Bradwell. You make a really, really important point, and having had a very personal experience of that at the weekend, because it's sod's law, it's always going to happen at the weekend, to have to drive myself, and I'm lucky I can drive, but 15 miles to be seen in a whatever they call themselves these days, but I'll call it A&E, and then to drive a further 15 miles to actually get the prescription. It's in a rural county. It is not a joke, and as I say, I'm fortunate I can drive. Derek.
This item, in terms of the pharmaceutical needs assessment, is a statutory duty. We need to make sure we do it, and we'll do it well. And a lot of what Councillor Bradwell said is built into the PNA process in terms of making sure we get that voice to the people of Lincolnshire about what they believe. But the outcome of it is a needs assessment. It isn't then a structured action plan about how we meet those needs, and that'll be a really important follow-on piece of work that we need to do as the Health and Wellbeing Board and through the ICS partnership arrangements is take on board what the pharmaceutical needs assessment is telling us and then do something about it. And I think that's true of the Joint Strategic Needs Assessment as well. It's a needs assessment. It tells us what the needs are. It doesn't, well, it should inform, but it doesn't drive at the moment what we subsequently do, and we need to make sure that we do that. I think the other bit on both of these is also an asset assessment. So the government says we need to have a needs assessment, whether it's a joint strategic one or whether it's the pharmaceutical one. We also need to understand what the community assets are, because those two things together will inform what we should do in the future. And I think the Health and Wellbeing Board will be central to that. So it's a specific project, a specific thing that we need to do, and we will. But we've got to take the findings of it and then implement different models of care, I think.
Thank you, Derek. John.
It's a bit like deja vu, because I was just I made the point that Derek made there. This is getting the GSNA done properly for pharmaceutical needs is really important. But the real question is, how are we going to use it in the context of actually delivering care and health across our county? And I'm sure we'll come on to it later, but I think the Health and Wellbeing Board probably already aware that the intention is that the statutory ICS, when it comes around, has more direct responsibility for general pharmaceutical, dental and optometry services in the same way that the CCG currently has for general medical services. So I think there'll be opportunities there for us to turn the advice and the guidance from the needs assessment into something more meaningful on the ground across our county. Thank you, Sue.
Thank you, John. And I think the other thing as well that adds to the complexity is particularly, well, it doesn't matter wherever you get to an edge of the county, you've then got to factor in that you're then dealing, and particularly with ICSs, the suggestion is them having the footprint of the local authority, that you then have to factor in those services that are provided by a neighbouring ICS for our own local residents. Councillor Wright, Richard.
Thank you. I mean, it might come as a surprise that actually sparsity isn't always an indicator of quality and quantity of service, and we pick this up through a lot of our wellbeing people and tenant services. So on that, and with Derek saying this needs to be done well, there's just a request that the districts are explicitly involved in the consultation, because quite often we've got data and information out there that would feed well into this, because sometimes that's just missed. So just a request to be involved in that.
Thank you. Okay, so if there are no more speakers, can we move to the actions required? And again, I shall do the same as before. We've got 3 bullet points. Are you all in agreement with those bullet points? Can you just raise your hands as a yes? Right. Okay, thank you. We now move on to item 8D, which is the BCF update. Glenn, I've got here that it's going to be Gareth that's updating us, or is it going to be you?
Thank you, Chair. I'm quite happy to be a stand-in.
Thank you.
So,
Hello, just say I'm on the call.
actually, Chair, if I introduce the item and then hand over to Gareth.
Okay, fire away.
As if by magic. The Better Care Fund will be a familiar friend to many of us around this board today. And for the last couple of years has been a roll forward with very little change introduced by the government. Indeed, the subsequent item on ICS has as much to say about the future direction for the ICS as what we might say today. But having come off a call this morning, I think it's highly likely that later this year, when the government introduces some reform for social care, it will also introduce further reforms to the BCF. Highly likely that the Better Care Fund will be a direct funded element into local government. There's a debate about the relevance of a national filter mechanism for approving Better Care Fund plans, but I suspect a lot of that will come down to health and wellbeing boards and integrated care systems in the future. We can expect that the government still has expectations about support to our local NHS community using the BCF. That probably will remain, along with supporting adult social care, of which, as it were, it is a fairly high feature element in the Better Care Fund. And just to remind members, this is important. It's 260 million pooled budget in Lincolnshire, one of the highest in the country, and likely to grow if we are to be successful in better meeting our community needs. And at that point, Chair, I'll hand over to Gareth.
Hello, everyone. I guess in this first time we've done this over Teams, it's a little bit strange. I can't see anyone else now other than myself. I think Glenn's really moved on what I was going to say following this conversation and the webinar this morning. So we're just going to focus on the reason why this has come back through the Health and Wellbeing Board. So we brought a paper in March which kind of highlighted the plans around potential for BCF planning and reporting in 2021-22. We're still awaiting that kind of confirmation about the planning requirements and the reporting requirements. But I mention that because part of the national conditions is that any submissions from the Lincolnshire system is approved by the Health and Wellbeing Board prior to it being sent through. So obviously in the paper there's an attachment which is the end of year report that went into NHS England for 2020-21. That was submitted the 24th of May. Usually it would have come through the Health and Wellbeing Board, but obviously with the impact of the local election and not until today confirming the chair and vice chair, that was submitted in consultation with John Turner as vice chair of the board. So now we're asking for retrospective approval of the board so that we continue to meet the national conditions for BCF in 2021. Obviously, as Glenn said, as we get further information about what's to come for the Better Care Fund, that will come back to the Health and Wellbeing Board as soon as we can do that.
Thank you, Gareth. Are there any questions for Gareth? Oh, you've got away with that fairly lightly, Gareth. No, I don't think there's any hands up. Oh, it's a good job because you've just disappeared.
Just to pick up with District Council colleagues, I'm fairly certain that the future direction of the BCF will include a stronger housing element, not just the BCF, DFGs, Disabled Facilities Grants, which in Lincolnshire, of course, is quite a valuable asset to us, 6 million plus, shared across the 7 districts. I suspect there's a lot more to come on the housing front as part of the BCF in the future. More to follow.
Did you notice how our district council leaders' ears pricked up at that? Goodness me, they were taking a lot of notice of you. So, Councillor Wright.
I'll just start with, you're not giving money away, you're passporting it. No, on that, I mean, we'll deal with that as it comes through. But in the meantime, obviously, we have got the DFG system in place, and I know there's been previous conversations about pooling, and it's just to make to make the point that there's no issue with the district councils working together on joint projects as long as there's a business case put forward for a specific project rather than pooling of the whole lot. So it's just to make that clear.
Councillor Bowkett.
Thank you. I'd just like to remind Councillor Wright that under the Health Housing Care Delivery Group, we have actually, all 7 districts have actually agreed to pool money for joint projects within the 7 districts in County Council.
Yeah, I was just making the point because there was some confusion that it had been agreed to pool all of the DFG money, regardless of whether there was a business case to actually look at projects.
Sorry, can I just come back? Certainly not pool all of it, but some of it too, because obviously some of the districts, or most of the districts due to COVID, haven't spent all their allowance, and I think it's just an ideal opportunity that we can actually use something for housing or whatever it is across the county for a useful purpose.
We're in agreement.
Any other comments at all? Thank you. Okay, so can we now move to the, hang on a minute because it's all gone quiet, the actions required that the Health and Wellbeing Board approves the BCF final report 2021. Are you all comfortable with that? Okay, thank you. Thanks very much. We now move on to an item. Derek, I believe you're going to give us a verbal update on the COVID situation.
Thank you, Councillor Woolley. I'll keep it fairly brief. The data at the moment is showing that on the national government website, which is data up until sorry, bear with me a second, 16th. The England rate is about 90 per 100,000 for COVID, so it's definitely going up, as I'm sure all members are aware. The Lincolnshire rate up until the 16th on the government site is about 40 per 100,000. When we look at our internal data, so coming back to this thing about us trying to make sure that we've got data and we're turning it around quickly, we have data internally that is up to the 19th, and actually it's just been updated. Up to the 19th, our data showing our rate about 40, so it's gone up slightly, but not hugely. And then the data that's just hot off the presses is 41. So we're going up approximately 1 per 100,000 every day. Now, when you look at what's happened in other parts of the country, in Bolton, Blackburn with Darwin, parts of London, they have seen quite quick acceleration away. To some extent, it was exponential, so it wasn't a straight line increase. It started going up like that. We haven't seen that. We've been very straight line. Very, very early indications that the rate of increase is starting to level off. We're not going down, and I don't expect us to go down for a while, but we aren't accelerating off. And if anything, our rate of increase is slowing, which is all really positive news, and it's a reflection of our vaccine rollout. As everybody here will be aware, we have an older population in Lincolnshire, and given the Joint Committee on Vaccination and Immunisations approach, that meant we had to vaccinate a lot of people very quickly. Vaccination programme has been phenomenally successful, done a sterling job, and where we are at the moment, again, these data will be updated, but we've got in the region of 78 to 80% of our eligible population, so that's 18 and above or 16 and above if 16, 17-year-olds have an underlying health condition. Between 78 and 80% of that population have had at least 1 dose, and around 63, 64% will have had 2 doses. And we know that whilst no vaccine is 100% effective, all of the vaccines that we've got are effective, and they're certainly very effective in terms of even if you're going to catch the disease afterwards, it will minimise the severity of the disease, it will minimise the likelihood of having needing NHS care and treatment and hospitalisation, and reduce significantly the likelihood of death, and we're seeing all of those data. So whilst the data is going up, we are seeing what the rest of the country is seeing, an increase in Lincolnshire in the number of people who are catching COVID. It's predominantly younger working age adults. The vaccine programme is definitely significantly reducing the link between the number of cases and the amount of people who need NHS care, and obviously the amount of people sadly who lose their lives to COVID. And there's very early indications that we may be seeing a slowing down of the rate. Obviously, we keep a very close eye on this. I look at it at least 3 times a day. If we start to see that pattern emerging, then we will be making sure all partners are aware of that. Happy to take any questions.
Thank you, Derek. Any questions for Derek? Oh, there you are. Sue.
Thank you, Sue. Thank you, Derek, for that update. Looking at the news this morning, the media is talking about sort of autumn boosters. I mean, or certainly for the vulnerable. Will you have any updates on that, or whether that's likely or not? Thank you.
I'll do a little bit. I don't know whether John will want to jump in as well. At the moment, there is a clear strategic direction to give a booster jab. What we don't know yet is whether we can, who will be eligible for that vaccine, which vaccine it will be, although the indications are if you've had 2 doses of the AstraZeneca vaccine, you'll probably get the Pfizer vaccine, because that is likely to give a better coverage and a response, an immune response. But again, that'll come out. And a key question about the logistics of this: can you have your booster dose for COVID at the same time as you get your flu jab? And if the answer to that is yes, then that will be really important in terms of making sure we get really good coverage of both. I was just talking to Sunil before we came in, and the government and lots of us share a real concern that we need to make sure everybody gets their flu vaccination this autumn and winter. As I'm sure members are aware, we haven't had flu. We haven't had flu at all over the past 18 months, really. And that's true in the Southern Hemisphere as well. And the flu programme looks at what's happening in the Southern Hemisphere, which flu strains are circulating. There's normally a couple of A's, a couple of B's, and another. And then we put those into the flu vaccination, into the actual flu jab. And that then gives protection for the Northern Hemisphere, because flu mutates every year. And that's why you need a new flu vaccination every year. Because we haven't had flu, we don't know necessarily what we're going to get this year, which means it could be a big risk, especially if we don't have a good coverage. So that's where we are. As soon as we find out, we have a multi-agency flu programme that's tied in fundamentally with our COVID vaccine programme. The two will link together, and ideally we can give both at the same time, but if we can't, then the logistics will be worked through. But it will be led through the NHS, so I'll pass over to John to add to that.
You've covered it really well, Derek. I think the only couple of points I'd like to add is clearly within the NHS we are thinking about how we're going to mobilise or keep the troops mobilised in terms of the booster programme into the autumn, and we wait further guidance and nationally in relation to that. Just to go back to our vaccination programme, clearly it has gone superbly well in the county, thanks to the tireless efforts of literally hundreds of people across Lincolnshire, making it happen over what's quite a long period of time now. But I just wanted to say that in broad terms, the performance of the vaccination programme in Lincolnshire is well up there, sort of in the upper quartile across the whole of the country. I certainly expect that we will well exceed the national targets that are required to be met over the coming few weeks. But we just over the next, every day really counts in terms of pushing on with the vaccination programme. So I think we're in a good place with that, but absolutely no complacency at all. Thank you, Sue.
You may.
Sorry, it would be remiss of me not to also say that whilst we've done a really good job with the flu vaccine rollout, and while the data is starting to indicate it might be getting better, we can't forget our basic messages, which is hands, face, space stays the same, as does making sure we get plenty of fresh air if you are indoors. And secondly, if you get offered the vaccine, please, please, please take it up. It is safe, it is highly effective, and if you've got any concerns, you can speak to your healthcare professional and get those dealt with. But the more people that get the vaccine, for those small number of people who can't have it because of other pre-existing clinical needs, those people who've got the vaccine protect others who can't have it. So it's really key that we remember those messages, regardless of where we are on a national picture. Hands, face, space, fresh air, and get your jab.
Thank you, Derek. Tricia.
Thank you. Does that mean I can play golf every day then? Do I get 4 hours off every day to get my fresh air? I'm going to tell the leaders that. Seeing as I don't really get a chance to play once a week. But anyway, by the by, just check. I was just wondering how we've done with, if you look at the population down in the Boston area, and we know we've got Eastern Europeans working on the farms and in the pack houses and that. How have we done with that, you know, cohort of people? Because obviously we do know, I know Richard with Moy Park had a little bit of a issue, didn't he, there when we were, I think it was the first lockdown, wasn't it? I know it was a big one, but you dealt with it very well. But you know, it is those sort of occupations, and obviously now, you know, they will be going to work on the land, and obviously we know people work very closely, but that's just one area. And then my other area is the coast, because obviously lots of people come in there to do the summer seasons and things like that, and sometimes they stay, and it's about picking people up, isn't it? But I know it's very difficult when you've got a transient population probably, but you know, we've all been very good, and when we've been offered the jab have taken it, but there are a cohort in our populations who won't be doing that, and obviously they're the risk probably, aren't they?
Derek.
Yeah, we've been working really closely with our NHS colleagues just to try to make sure, and actually with the district council have been fundamental to this, to access those communities, to make sure that we're giving the messages in the right way, in the right language, through the right mechanisms to get people to come forwards. It's absolutely true to say that we have seen historically outbreaks in certain areas. They tend to be those areas where we have to carry on working if people want fresh fruit and vegetables on their tables, and obviously that's been really important. It's very difficult in some of those settings to maintain the level of social distancing that we would have normally, but it's equally really important that we roll out the vaccine programme. I know Boston's figures are coming up. You would expect Boston and Lincoln to have lower figures because they've got a younger age population than, say, the East Coast, East Lindsey. I think we're up to about 65% coverage in both Boston and Lincoln, and it's on its way up, and around more than 50% in both areas for 2 doses. So they are going up. They will be behind the curve because they've got a younger population, so they haven't been eligible as long, and they will be behind the curve because they have other populations that are more, that we have to work harder to make sure we get the right engagement and that we deliver the messages in the right way. But there's a huge amount of work going on at that. I don't know, again, whether John wants to jump in on that one.
John.
Have you been into the factories and done vaccinations there? And likewise, I can't remember the big farmer. What's the big farmer? Yeah, there's some big farmers, and I can't remember the name of them. Okay, John's coming in.
Thanks. I mean, the short answer is yes, we're doing a lot of activity on that front, Tricia. Just to give you literally hot off the press, just to give you a few figures. So in Lincolnshire, we've got a GP registered population of 651,000 adults across the county. Of those who are aged 50 and above, or between 18 and 49, but who are clinically extremely vulnerable, 88% have had 2 jabs. That's huge for us. And equally, in terms of the total population, about 2/3, just about, have had two jabs as well. The challenge for us that we're finding isn't so much the population who are registered with the GP, but it's those who aren't registered with the GP. So there's been a lot of activity across the county, but particularly, for example, in the south, of going into the factories and the agricultural settings and offering bespoke sort of vaccination clinics effectively. We've worked closely with a lot of employers across the county to get access to their workers. We've had stalls at the Boston Market, and just on Saturday just past, we started the first of 4 what we're calling Super Saturdays in Lincoln, again, which are picking up people who haven't yet been vaccinated. Quite a number of those are people from Eastern European background who aren't registered with the GP, but also a few local people who, for one reason or another, didn't get their vaccination the first time round. And then finally, we have now for, 2 or 3 months, if not longer, been working really closely with the district councils, who collectively have set up a sort of health inequalities type group with the CCG team, and there's a whole raft of actions that are taking place across the county in relation to this. So the teams are working really, really hard in trying to make sure that we don't leave anyone behind at all in relation to this. And it's that work with the district councils actually has been highlighted not just by our Midlands region, but also nationally as a best practice sort of exemplar. So I think we're doing all we can, but we need to continue, don't we, just to reach out to every corner of every community that we can. But as I say, it's potentially those people who aren't registered with the GP who we now know we need to pay particular attention to. Thank you, Sue.
Kellen.
Thank you, Sue. I don't wish to elongate the process. I was pleased to get my first jab the other day, so I've still got a few weeks to go for my second jab. In terms of the booster jabs, though, are we going to start looking at doing sort of later appointments to enable those that are working to potentially just drop in a bit later on? Because I know in some other cities, particularly the younger population, I mean, if I got the call at 1 o'clock in the morning to go for my first jab, I'd have gone. But are we looking at doing later appointments for those that are in work as such?
I think we're looking now at particularly over the next few weeks of clearly now we're opened up to 18 and aboves, and you'll understand that prior to that, we were a little constrained in terms of working our way through the cohorts. The task in front of us now is to get as many people jabbed first or second time round as we possibly can. Obviously, for the younger cohort, that will be first time round. So I know the teams are looking at all sorts of different ways in which we might do that, Callum. So I'm sure they'll be looking at the sort of evening clinics. As I mentioned earlier, we've got the sort of vaccination boss that has been going around and just sort of almost on the spot being able to provide vaccinations for people. And certainly I heard Sunil, the one in Lincoln on Saturday, there was a constant queue outside. So I think you make the point really well, Callum, that we've just got to be as flexible as possible to get absolutely as many people as we can.
Maz.
Thank you. I just wanted to say that actually our large vaccination sites at the Lincoln Showground and at the Princess Royal in Boston do actually run till 8 o'clock. So 8 till 8, 7 days a week. So we do and are offering evening appointments.
Thank you. Just to complete your data set, as it were, we currently have 2 positive inpatients in the hospitals, both at Pilgrim. Thank you.
Thank you for letting us know that. Are we allowed to know whether those individuals did have a vaccination or not?
Off the top of my head, I don't know the individual status. My learned friend does.
I'm not sure they're the same two people, but this question did come up last week at the Outbreak Engagement Board. I think at that point we had 3, and we did check with our colleagues in the trust. None of those people had any vaccination at that point, and we're just looking at the data flow to make sure, and obviously confirming with clinicians that it's okay to provide that data in the future. So in the future, we should know if we've got 2 people, have either of them had any vaccination, and if so, 1 or 2 doses. So it'll be another part of the data set, subject we've just got to get approval for that.
Thank you for that. Derek, there are some people who have never had a flu jab. How are you going to sell it to them that there was no flu effectively last year because of the COVID jabs? What's going to prompt them to have a jab in one arm and a jab in the other arm?
I think the key point to recognise is that we want to get back to a new normal, don't we? We want to be able to meet our friends and families. We don't want to have to maintain social distancing, and we need to recognise, and I think everybody's there, that we have to live with COVID and we have to live with flu. And we have always had to live with flu. Now it's about recognising, and I think everybody can see, the risk that infectious diseases do pose. We often have anywhere between, it can be 2 to 30,000 people who may die from flu in any given flu season. And a lot of that is a function of 2 things. 1, the strains of flu that are going around, and 2, the number of people who get vaccinated against it. So I'm really hopeful that we can take what little positives that have come out of COVID, but one of them is that we can respond as a country, as a world, to make sure that we get the right vaccination and we mobilise that really quickly. And certainly the people of Lincolnshire, as we've just talked about, have done a great job of getting their vaccinations. If we want to carry on, if we want to get back to our new normal, if we want to enjoy all the things we enjoyed before, the best thing to do is have your COVID vaccination as soon as you can, and to make sure, if you're eligible, you get your flu vaccination. It protects yourself, protects your loved ones, and really importantly, it protects everybody else who hasn't had the vaccine, and that's an important part of this.
Thank you. Okay, and thank you for Richard.
If I can, thanks. And Derek, I think, is going to know what I'm going to say. It's about comms. I go on about this at Low Web all the time. I think it's going to be about getting the comms at the right time, at the right level, aimed at the right people, because that's what's worked effectively over the last few months. Because most people, especially younger people, are going to hear flu. And how many people say, oh, I've got flu, when we know they've got a cold? Because flu knocks you off your feet if you have it, as we all know if you've had it. So it's about that. And if it's the younger people raving it out, if you just advertise free shots, we'll get them through the door. No problem at all.
Thanks for that. Okay, and thanks very much for the update, Derek. I don't think there are any further questions. So we'll now move on to 9B, which is the ICS update. John.
Thank you, Sue. There's a huge amount of stuff going on in the ICS world at the moment. We could spend a long time, looking at all of the different elements, and it might be worth a workshop or something like that in its own right at some point during the year. But it's a very, very busy space. But I'll try and keep it relatively brief and some key points. And then perhaps Glenn might just want to come in with a few comments, and then open it up for colleagues across the room, Sue, please. So just in terms of a few kind of key points, at the forefront of my mind, and I'm sure our minds, is the development of the ICS has to be with a purpose or number of purposes. Fundamentally, this is about better meeting the health and well-being needs of the people of Lincolnshire who we collectively serve, and it's about how we work together as proper equal partners to do that to best effect. We only have to look at how we've all worked together, not just the NHS and local government, but our colleagues in the third voluntary sector, in the care sector, across the whole patch really, to know that we have done collectively a superb job in meeting the challenges that the pandemic has brought to us and the health of the people in Lincolnshire. So we know how to work together, we know how to do it in partnership, we know how to make sure that everybody's given the opportunity to contribute to it. And I think that that's going to be a core ingredient if we're going to make a success of the Lincolnshire integrated care system. And the final sort of opening comment I would say is the integrated care system, according to the guidance, is here to deliver actions against 4 core purposes. Now these, in a sense, are quite new to the NHS. Some of them are anyway, and I think in a way play more actually to the experience and perspective of the Health and Wellbeing Board rather than just the internal NHS organisations, hence why we need to work together and in partnership on this. So the 4 core purposes are to improve the outcomes of the people we serve in population health and healthcare. Number 2 is to tackle inequalities in outcomes, experience and access. Number 3 is to enhance productivity and value for money. And finally is to help the NHS support broader social and economic development. Now that is new space for us in the NHS, but I think that all of the work we do together and the way in which we create and design our integrated care system in Lincolnshire needs to hang off those 4 core purposes. I think we do have a decent track record of working well together in Lincolnshire. Certainly we on the NHS side of things recognise that we have, until relatively recently, been pretty fractured. We've been working hard over the past couple of years to present and to be much more joined up in the NHS and to present and work with you all and our other partners as a joined up NHS. And I think we've come a long way with that. There's always more to go, of course, but just for example, the creation of the single Lincolnshire CCG from the previous 4, I think is a good, hopefully a good example of that. The national expectations around developing integrated care systems was first established in early 2019, and in April this year Lincolnshire became designated as an integrated care system in the sort of partnership model along with 42 other systems across England at that point or some prior to that point. So the whole of England is now covered with ICSs as partnerships. Clearly the white paper on health integration and innovation was published in February, and the intention of that is to create statutory integrated care systems from April 22. That is subject to the passage of legislation through Parliament, and clearly that is yet to happen. So we can't get ahead of parliamentary process clearly, but we are obviously thinking about how we are going to make this work for April 22. It does envisage an integrated care system for each geography. As I say, Lincolnshire is one of 42. The latest guidance actually only came out on Wednesday last week. I can't believe it's not even a week yet. And so that guidance has been made available to all members of the boards. So clearly we're sort of working our way through that. There was nothing in it that particularly surprised me. Certainly the guidance, as I understand it, is seeking to be very sort of permissive. So what that really means is they want local systems to design, own, develop integrated care systems locally for their patch and their population, and the amount of guidance that's going to come down from on high to us is fairly limited. Now, that is quite a significant development. I think when I think of the previous sort of 3 or 4 NHS reforms, it has been more a sort of kind of one-size-fits-all sort of approach. So I think they are genuinely trying to recognise that there's significant variability across the country, and we in our local patches are best placed to determine how we can work together to meet the needs of our local population, as determined by the JSNA, amongst other things. I also understand that in parallel with the guidance that came out last Wednesday, that the department and the LGA are looking at developing some further either guidance or you know, sort of suggestions across the country about the partnership element of it. I don't know when that is likely to come out, but clearly that is a fundamentally important part of the whole piece. We know that the integrated care system that we will have envisages there being one health and care partnership board in each ICS, and we are well on the way to evolving our health and wellbeing board to take on that role. I think we're very fortunate in the county in that I think everywhere else, and certainly the NHS Midlands region, has more than one health and wellbeing board within it. So they've got their own challenge in relation to that. And clearly it envisages there will be an NHS ICS statutory body, which for us would just be called NHS Lincolnshire, I think, into which all of the CCG's current responsibilities and functions will be, moved over and into, as the CCG comes to an end, as I say, envisaged 31st of March next year. Plus, it will have responsibilities, as I previously trailed, for general pharmacy, optometry and dental services that are currently commissioned by NHS England. And it also will have, it seems, particular responsibilities for digital and data and for people as well. Both of which we do a lot of good work together on across the broader system already. The guidance also describes what the minimum requirements of an NHS ICS body board would look like, and you'll see there that there would be an independent chair, a couple of non-executive directors, four executive directors, and then 3 what are called I think partner members. I might have got the terminology wrong, but one from local government, one from primary care, and one from providers. And clearly, you know, we'll need to see how we think our way through that as well. And then just a final couple of points from me, and I'm very happy for others to come in. As I said at the top, I think this is about a partnership of equals if we're going to make this work for us. And certainly that I think I can envisage us being quite successful in Lincolnshire in terms of how we make that happen, because we don't have the same complications that many other parts of England seem to have. And then we talk about systems, so we'll have a Lincolnshire integrated care system as if it's some sort of hermetically sealed unit, which it isn't. A great many of the Lincolnshire population looked at other areas, be that, for example, Peterborough to the south, or North Lincolnshire and Gould to the north for their care. And so the way in which we work with other systems, our neighbour systems, I think is fundamentally important, because it's not just a few people in Lincolnshire, it's a very significant part of our population. And then finally, my personal thought is that integrated care is as much a way of working, arguably much more a way of working, than it is about structures and organisations. And we mustn't allow ourselves, our energies and our focus to be unnecessarily distracted into structures and organisations and governance, really important though that is, away from the core mission, which is about how we deliver on these 4 core purposes: to improve health, tackle health inequalities, enhance value for money, and support broader social and economic development. Thank you, Sue. I'll pause there.
Thank you, John. And before I bring Glenn in, I think it's really important that those of us that are probably not quite so steeped in the NHS side of things, that there are 2 separate boards. And so when you were talking about the ICS NHS body, that's more for me, in my simple little world, the operational arm of what gets done, whereas the partnership board feels more like the offering the strategic direction for us as a system, as probably oversimplifying it, but is an easy one then to certainly understand, and why you would have wider partners in that partnership board. So Glenn.
Thank you, Chair. So this isn't new. We've been working on integration and common purpose for about, well, nearly 40, a fair while. Although the NHS only had its 75th birthday not too long ago, so probably about 60 years, I think. Certainly during my career, which doesn't quite stretch that far. I think it's important to remember that Lincolnshire is in a good place, not just because of the existing structures or government exhortations or policy directions, but because it's the relationships that make this work. And I was on a call just before I came in here, Chair. NHS is setting up a whole range of national briefings. There's about 415 colleagues on the call. And I was basically talking to them about the importance of recognising it's the relationships that make this, not the acronyms, the narratives, or the structures. The better performing systems we know are ones that have a pre-element of relationships. BCF is an example of that, and we've got a large area of pooled budget for that. I think it's also important to recognise that some of our key partners, the voluntary sector, social care providers, who represent a much more dispersed set of provision in the council area, have also found common voice, which helps them contribute to the richness of our own debates and discussions and plans. One of the things that intrigues me, and John made the point, which is one of the core purposes is efficiency. It gets later translated as productivity in the ICS framework that was published last week. And that's all about working closer together, because more units delivering different and disparate services costs more. It doesn't deliver better outcomes, and that's a message for us all. It should also be said, I think, that we are very fortunate here because we're coterminous. Essex has 3 ICSs, although the Secretary of State is minded to change that so that it becomes coterminous with the upper tier authority. And if we can continue to work through the existing structures, the existing assets that we've got, we will go further faster. There's a lot of resource at stake already that we could use better. And I think the comment that was made to me from this morning's get-together was, if you are already thinking and beginning to use your Health and Wellbeing Board as the ICS Partnership Board, that's a wonderful opportunity for you, and I envy you greatly. And that was the Chief Executive of a London borough.
Well, I have to say, Glenn, I'm in full agreement with you there, because as I started to say at the very beginning of this meeting, it felt a bit lonely that we seem to be the forerunner as far as subsuming at the moment our partnership board into the Health and Wellbeing Board. But I am delighted to say there are a number of local authorities who are now starting to come to us and ask exactly how we did it and what we're doing. So I'm quite convinced that as a system, we are heading into the right place, and hopefully you'll be agreeing with me, John, and indeed all of my colleagues as well. So thank you for that, and thank you for the update, John. No other speakers at all? No.
Yeah, one of the, I mean, we are calling our integrated care systems the Better Lives Lincolnshire Alliance. So that's the sort of banner that we would like to try to develop our partnership and joint working on. I agree with you. The system in itself kind of sounds like it's quite mechanistic. It's quite cold, isn't it? And I don't think it necessarily conveys the feeling that we would want to have in Lincolnshire. The terminology integrated care system, I think, was first coined in terms of national policy. It was certainly in the NHS long-term plan of January 2019. May have been around a little while before that. I think rather, given that this is highly permissive, I would hope that we could call ourselves whatever we felt was most appropriate for us in Lincolnshire. Even though to the outside world we might just need to call ourselves the Lincolnshire system. I think you're spot on, Tricia, actually, because a lot of the feedback I get from members of the public is along the lines of how fragmented the services are that they receive as patients and as members of the public, and almost a little bit, the more you can just join up, not just within the health service, but with others, the better it will be for us, our families and our communities. And it's that, I think, that we're trying to express, isn't it? Thank you.
Thank you, John. In that case, if there are no more speakers, this is just an item for noting, so hopefully.
Sorry, Chair, I don't know if you were going to get to it, you probably were, but just to remind you that John suggested that perhaps Health and Wellbeing Board might want a workshop on this.
He did, you're right. Alison.
Obviously, we can't arrange anything until the restrictions are lifted, hopefully on the 19th of July. And I think we'll probably be looking to do something in September and avoid August.
Yeah. If I'm honest, ideally, the meetings, because we only have a few meetings each year, in between those meetings, I think that's the opportunity for all of us to have an informal setting and probably invite our wider, say, some of the non-executive directors, wider members within the councils, those wider partners, as I mentioned earlier, the university and perhaps workforce and people like that. But that would then be a mechanism for us to draw in those wider partners. So hopefully you'll be in agreement that, as I say, we slot those in between the main meetings. Okay. Now move on to our next item. Councillor Bopitt, are you going to introduce this item, or are you speaking to it, or doing both?
I'm doing both, and then Sean's going to come in as well if he needs to add anything after, if that's okay. But I think he's going to be on the screen, isn't he? Yeah. He's there, look. He can't see us, but we can see him. And he's even had his hair cut, so that's good. Right, so this report presents the Housing, Health and Care Delivery Group delivery plan to the Health and Wellbeing Board today. The plan has been developed by a small working group and was agreed by Health, Housing, Care Delivery Group at a meeting on the 30th of March. For anybody who doesn't know what the Housing, Health and Care Delivery Group is, it was a group created by the Health and Wellbeing Board about 4 years ago now. I've chaired it for the last 4 years, and it's about getting all partners to work together. So we've got all the 7 districts around the table. We've got police, we've got county council, we've got health, we've got DWP, CCGs, you name it, we have them all sitting around this table. Together, we've formed and agreed this delivery plan. The delivery plan is actually formed for the Homes for Independence blueprint, because as we all know, housing and health go together. If you have if you live in a house that's got poor heating or lack of heating, it's cold, you get lots of illnesses from that. And we've agreed around the table that we need to work together to improve housing across Lincolnshire. So we've took this Homes for Independence blueprint to all the 7 districts, and we have got every one of the districts to agree it and to actually work with it. So they've all signed up to it, County Council signed up to it, the police have now signed up to it as well, along with the fire service as well, they've signed up to it. So we're all going to work together to try and improve housing and along with the health, which obviously goes together. The delivery plan is a working plan. This is not just to be formed, we've not just written it and we're going to put it on the shelf and that's where it's going to stay. It's a working delivery plan that we've got partners around the Health, Housing, Care Delivery Group doing different things on that, and they will keep coming back to each meeting and updating us as we will be bringing it back to the Health and Wellbeing Board as well. So I think it's really exciting. I think it's well needed along Lincolnshire, and everyone working together I just think is absolutely really, really good, and I'm really, really proud today to bring this here. Do you want to add anything else, Sean?
Yeah, thank you, Councillor Barker. You've done an admirable job of saying almost everything I'd written down to say anyway. Just to add to the list of people that have endorsed the blueprint, we've also got the endorsement of the Greater Lincolnshire Housing Association Partnership, which represents all the registered housing providers across the region. So I was just going to reiterate the fact that this is a live document. The blueprint is now fixed and published, and that has set the delivery objectives. But the actions that you see in the delivery plan, new actions can be added through any Housing, Health and Care Delivery Group meeting. Similarly, if actions are no longer appropriate, and I'm already looking at the second one that says we will complete the insecure homes and homelessness JSNA topic, that probably needs to be replaced now with looking at insecure homes and homelessness throughout the life course relating to children and young people, working age adults and older people. We'll also use the document as a record of outcomes so that rather than just lose an action when it's completed, this delivery plan will show what the eventual outcome from the action was. I just wanted to draw board members' attention to the column that sets out the delivery partners. You'll notice then that the column next to that, timescales, is blank at the moment. The next stage is for us to work with each of the groups that will be party to delivering actions to agree with those groups and the lead organisation the timeline within which it's feasible to deliver these. We'll then be, through Housing, Health and Care Delivery Group, holding those lead agencies to account, if that's the right terminology, and using this document as a means of reporting back to the Health and Wellbeing Board on an annual basis what Housing, Health and Care Delivery Group is currently doing and what it has done in the past year. Thank you.
Thank you, Sean. And I'd just like to thank Sean and Sam Neil for all their hard work in this, because it's, they have done a tremendous job, along with everybody else sitting around the table on the Health, Housing Care Delivery Group, because we have all worked hard to get this here today. So thank you.
Thank you very much, Wendy. And again, I go back to the pride that I have in Lincolnshire from the point of view that this particular priority around health and housing was, we felt, very important when we were pulling together the joint strategic needs assessment and then the strategy. And we were, again, one of very few councils who had even considered putting housing as a priority around health. So, you know, we lead from the front. John.
Thank you, Sue. If I could just add my support and thanks for the work Wendy, you and Sean and the team do on this. Certainly sort of my circles at sort of regional and national, the importance of housing is increasingly coming into to the discussion. In a way, it certainly wasn't, 12, 18 months ago. And I do feel that in our own understated way in Lincolnshire, the work that you and through the Health and Wellbeing Board previously have already got going on health and housing sort of puts us in good place, so you can just see it continue to build and evolve really successfully as part of our integrated care work. Thank you.
Thank you. Richard first.
Thank you. As Wendy said, I think it's excellent. Everybody's working together on this. And there are some quite challenging situations to be overcome. There's a lot of work that needs to be put in there, and it's not going to be easy, but then things never are, and especially if they're worth it, as this is, because, as you say, the link between housing and health might not have been there before, but if the longer we can keep people in secure, safe homes that are fit for purpose, then the longer we keep them out of hospitals they don't need to be in. But just to pick up on it, just a point to make is that Sean just covered this about the fact that the completions that it's being looked at. There is just that question about putting timescales against some of these, and if it's if organisations are coming up with feasibility, then let's make sure it's evidence based, so it can be challenged if need be. Because what we don't want is any kind of delay where there doesn't need to be any, and that we should have everybody working together at the same speed where we can. So feasibility needs to be properly driven down into, I think, to make sure that we don't turn feasibility into excuses, which unfortunately we can do as we go along. But I know from a district point of view, and Wendy will know this, that we're committed to this because it's something that we can really add the value to.
Thank you. I just want to say really welcome the paper. I've got an observation and a question, if that's okay. So from a community health services, obviously providing care in the home day in, day out, but also particularly with our specialist services for TB team. One of the things I do hear is around the home environment. So the home environment being the right place, particularly if you've got respiratory problems, and how that environment. One of the things I heard from my TB team just recently was really great that we're getting people into accommodation, but then just to have something of the basics to help them with their health needs of the environment is also really important, which probably leads on to my next question. We've seen in the media time and time again about restoration of services in the NHS and waiting lists. Have we found ourselves in a similar position with housing and backlogs of maintenance and services due to the pandemic? I don't know, Sean, if you're able to answer that or not.
There may well be other people better placed than me to answer it. I think there was an initial delay in some services when the pandemic first hit, but district council housing teams in particular worked really, really quickly to overcome those and find a safe way of working and to continue to deliver essential repairs and indeed aids and adaptations throughout the last year.
Yeah, I'd agree that, and certainly in East Lindsey, and I'd say Richard would agree with it as well, and Callum, that we've gone in there, and with what the government have been giving us powers on our enforcement, we've certainly in East Lindsey we've been working with private landlords as well as our platform homes to make sure that housing standards are raised. So yeah, I think we're all working to that. And just on what Richard's just said, I'd just like to thank NK because they are one of the first that's actually put the Homes for Independence in their planning and they've agreed to put it in their planning don't know, rules isn't the right word, but and East Lindsey, we've just put it through planning as well, so we've agreed that. So we are expecting the other districts to do that as well. So we're watching this space, Callum.
She can be very menacing sometimes, can't she?
I'll leave that to you then, Sue, to pick up.
Sean.
Yeah, thank you very much. And it's great to see this piece of work. It's dealing with one of the biggest determinants of poor health. And it's a bit of a surprise to hear that others are not tackling it. But anyway, that's where it goes. My question is really about resources and whether you see any resource bottlenecks in keeping this programme on the road. And if there is anything like that, then is that something that you need to be anticipating and shouting up? And then the second thing was about consistency of approach to business cases and competition for resources, financial resources particularly, and how that's going to be handled across the whole county. Are there other mechanisms that are clear about that?
Do you want to go on that, Sean? I'll pass that one to you.
Thank you. Resources, yes, will be a challenge. There are limited resources at the moment, particularly for private sector homes and for renewal, repairs and improvements to those. Things are changing around the energy efficiency world with the decarbonisation agenda, and we are putting in bids for substantial sums of money to hopefully install sustainable heating systems in people's homes along with insulation. For other issues, whilst there will be some of that money available for repairs that are necessary to enable those energy efficiency improvements, such as repointing walls before you apply solid wall insulation, there is still a big gap, and that's where I hope the point Glenn made earlier around watch this space on the Better Care Fund comes to fruition, that more money does become available through that route to fill some of the gaps.
Just coming back as well, and it's also about, this is what we were talking about, pooling DFG money, so that we can, and using DFG money as well, so that we can help people to better their homes, because it's not just about putting a shower in, it's about improving the way they're living. And if we can do that and use DFG money in a more better way, it's not better ways, that's not the right word, but it's just about looking together and seeing what we can do with the amount of money that we've got. It's not a bottomless pit, but I mean, working together, I just think we can make some real improvements. And especially, it's not just the older homes; it's building newer homes as well. Starting from scratch, it's talking about homes. What I would call not homes for independence, but I wasn't allowed to call it this. I wanted to call it a home for life. Because if you build a house, you should be able to live in that house for the rest of your life. At the minute, builders don't do that. They don't make the doors wide enough so you can get a wheelchair through. They put 5 steps to get into that house. And this is what we're trying to get all the districts, which they are doing. They're all being really good and trying to work with builders that's building houses in their districts, just so that we can have these homes for life. So you don't have to move. If you want to, yes, but if you don't have to.
Derek, I'm so sorry. I'm afraid I couldn't pull in.
Thank you. I just wanted to pick up the resource point, because it's a really good way to tie a lot of the items we've spoken about just now. So I'll give an example that maybe will help, maybe won't. If we've got somebody who's got asthma, who keeps going to the GP, who keeps dialing 999 because of shortness of breath, can't breathe, keeps getting transferred into A&E, potentially gets admitted to hospital, and actually the GP's doing everything that they can, they're following all the right guidelines, but the cause of that exacerbation of asthma is a cold, damp house. Firstly, for that person, it's a horrible situation to be in. Secondly, it's not a solution the NHS can deliver. It's a wider partners solution. And thirdly, by delivering a dry house, a warm house, changing the central heating, changing the windows so that person lives in a warm, dry house, we will save the system, to use that word, a lot of money, and most importantly, give that individual a much better quality of life. And that's where this particular agenda item cuts across, and why the Health and Wellbeing Board is really important to look at housing, because the different parts of that pathway for that person sit with district council, county council, public health, the GP, the CCG is the Commissioner of NHS Services, the Acute Trust is the deliverer of this, and actually EMAS as well, our East Midlands Ambulance Service. But if we don't do it together, then it's not going to get done. So I think it's a really good example of where, at the moment, the Health and Wellbeing Board and the ICS Partnership Board's got to go into these spaces. And I think, as John said, and you said, Councillor Woolley, we're ahead of the game because we're already quite a long way down that. But we're going to have to look at our resources differently, because if we keep them in all the different pots and don't do this collectively, we are not being efficient or effective.
Thank you, Derek. If there are no more hands, thank you, Sean, and thank you, Wendy, for your paper. And if I could just ask you all to note the actions required. Again, I'm not going to read them all out, but hopefully that's all, everyone's in agreement. Okay, thank you. We now move on to the final two items, which are simply for information only. And so we have the action log of the previous decisions, and rather than having the actions at the very beginning of the paper and then sort of losing them, there's an ongoing log so that we can see what decisions have been made in the past. So it's purely for noting, not for discussing at all unless you desperately want to. And then the final item, 10B, is the forward plan, and this is where I would really like you to have a think about it, have a chat with whoever, because we would more than happy need to bring some items to the forward plan and to this particular committee. So Richard.
On that point, so it's apparently previously district councils have been encouraged to put items forward for the agenda. Is that still the case?
Absolutely, yes, yeah. I'll reinforce it with this is the Health and Care Partnership for Lincolnshire, and all of Lincolnshire's got to be involved in it if we're going to make it work for our residents. So yes, please put anything forward. Alison.
If anyone wants to put anything on the forward plan, if they want to email the Health and Wellbeing Board email address, which is hwb@lincolnshire.gov, then we can make sure that happens, okay?
And on that note, I will close the meeting. Thank you. Really great thanks for your attendance. Yeah. I'll tell you now, everybody, it's a 2-hour meeting. And